Hi, everyone, and welcome. Thank you for joining our Take Diabetes to Heart webinar tonight. My name's James Farrell. I'm the National Manager Advocacy at Diabetes Australia. I live with diabetes, and it's my pleasure and privilege to facilitate today's conversation. Taking care of your heart is important for those of us who live with diabetes. And so as part of our Take Diabetes to Heart campaign, which aims to improve heart health outcomes for people living with diabetes, we're running this webinar to provide a safe and welcoming space to learn from our expert panel, who I'll introduce in a few minutes, about diabetes and your heart health. Can I begin the session this evening by acknowledging Aboriginal and Torres Strait Islander people as the traditional owners and custodians of this country? We recognise their connection to land, waters, winds and culture, and pay the utmost respects to them, their cultures and their elders past and present, and extend that respect to the Aboriginal and Torres Strait Islander people that have joined us for the webinar today. We recognise that Australia is made up of hundreds of different Aboriginal and Torres Strait Islander groups, each with their own histories, culture, language and belief systems. Their relationship with country remains of utmost importance, as it is the foundation for culture, family and kinship, songlines and language. Diabetes Australia is committed to improving health outcomes for all Aboriginal and Torres Strait Islander people affected by diabetes and those at risk. A couple of housekeeping things before I introduce our esteemed panel. I might just ask if we can flick forward a couple of slides there. Thank you. We would ask that you keep yourself on mute. We do have quite a large group of people joining us tonight. So we'd ask you to keep yourself on mute and keep your camera off. We are recording this webinar and so that we're able to share that with people who can't attend tonight. It'll be posted on our Facebook page in the coming days. We'd encourage you to share that with family and friends who might be interested in our topic. We are hoping that this will be a fairly informal conversation this evening, and so we'd invite you to submit any questions to our panel in the Q&A function that should be on the right-hand side of your Teams program. We'll try and answer those questions in our audience Q&A at the end of the webinar. And on to the next slide, Bridget, which has our agenda for this evening. So we're hoping to be chatting for about an hour, and it'll essentially be a few questions that we're posing to our expert panel, a couple that we've already prepared, and then really keen, as I said, for you to enter your questions into that Q&A box. So let's get on to introducing our panel, three experts in diabetes and heart health and three great friends of Diabetes Australia. So it's my absolute pleasure to introduce Dr Konrad Kangru, Yvonne Appleby and Hayley Nicholson. To start with, Dr Konrad Kangru is one of regional Queensland's most determined diabetes advocates. Dr Konrad has worked for over 20 years in general practice, and he's very active in the teaching of students and registrars, as well as ongoing education for GPs in his specialist area, which is diabetes care in primary health. Dr Konrad, welcome to you. Thank you. Our second panel member tonight is Yvonne Appleby, who's been thriving since her type 2 diagnosis in 2011 after having been ill for 7 years prior to that diagnosis. As a result of Yvonne's lived experience, she's passionate about helping to raise diabetes awareness and for improving diagnostic methods for early detection. By sharing her journey with diabetes, she hopes to make others' experiences less difficult. We're really pleased to say that Yvonne's a member of Diabetes Australia Community Advisory Council, as well as an ambassador and community awareness speaker and a consumer representative with Health Consumers in New South Wales. Yvonne, thanks for joining us and welcome. And our third panellist tonight is Hayley Nicholson, a dual qualified accredited exercise physiologist and credentialed diabetes educator who's passionate about working with people with chronic disease. Hayley's got 16 years of experience working across several areas of the health sector, including cardiac rehab, private practice, clinical education and management, and diabetes education. This experience allows Hayley to provide safe, effective exercise interventions and appropriate self-management strategies to ensure that her clients and the people with whom she works walk away feeling empowered and in control of their chronic disease management. Hayley, thanks for joining us tonight, and welcome to you, Yvonne and Konrad. As I said, we're looking to keep it fairly informal, we're in a conversation tonight about heart health and diabetes, and we're keen to get everyone's questions. I'll say it again. Please do enter questions into that Q&A box in your Teams function there. And then I'll be directing those questions to Yvonne, Dr. Konrad or Hayley. This might not be the right forum for all of the questions that you might have about this issue. And we, as always, we really do encourage you, if you have questions about this issue, to have a conversation with your GP and your treating team if there are areas in which you need to go into a little bit more detail. So while we wait for our audience questions to start rolling in, Hayley, I might start with you with a big opening intro question. What do we know about diabetes and heart disease?
Yeah, so we know there's a very strong link between particularly type 2 diabetes and heart disease. So we know that people living with diabetes are about 2 to 4 times more likely to develop heart disease. And it's also the leading cause of death for people living with type 2 diabetes. So I think it's a really important topic. I guess the basis behind how this happens is if you think of when your blood glucose levels are quite high in the blood, it pretty much makes the blood a little bit stickier and a bit thicker, and there's opportunities for that to stick to the walls of the arteries, and essentially plaque can build up. So I guess that's sort of how physiologically it happens. And once we've got plaque building up in the arteries, you can imagine when we've got a vessel this big, which is now this big, the blood pressure goes up. So that's often one of the things that people might notice is the blood pressure might go up, and also cholesterol levels that you'd be having checked with your GP as well. Along with heart disease, obviously diabetes affects all parts of the body because our blood feeds all parts of our body. So you might hear of other diabetes-related complications too, other than heart disease, so including stroke. People will complain of circulation in their hands, in their feet, and things like that. But heart disease is definitely one of the biggest issues. So I think it's definitely worth talking about tonight.
Hayley, thanks for that. I might come to you, Dr. Konrad. Talking about health can be a scary experience, and this topic can be a scary experience. As a GP, what advice do you have to people who might be a bit nervous or reluctant to have this conversation or to make an appointment with their GP around these issues?
Yeah, absolutely, James. Look, we completely understand why people might feel hesitant or reluctant to talk about these topics. We know that type 2 diabetes in particular is one of those conditions which is so still full of shame and stigma and guilt that to be open about it and to talk honestly can be confronting for some people. And in fact, sometimes you might feel as well, now I can't just see my GP anymore. Now I have to go and see an endocrinologist, or I have to go and see the specialist hospital about it because I can't have my GP anymore. We're very, very fortunate in Australia that GPs still and will continue to manage diabetes very, very well. Your GP has known you for a long time, long before this disease came into your being, and they're going to continue to look after you afterwards. So number one, trust your GP. Now, you will absolutely go and do all of the reading, and we encourage you to do that. You're going to get a lot of information from NDSS and a lot of other opinions, and you need to be able to differentiate what is real and what is not real. So I'd really suggest make a list. You write down all the things you're uncertain about. It's all well and good to listen to Today Tonight and Google and Facebook, but they don't know you like your GP does. So write down a list and take it in. And when you do go and make that appointment to go and see your GP, well, number one, make sure that you actually do book in for your GP management plan or your management plan review. That allows us as the team to put aside the extra time. You've also got some extra time with the practice nurse and with the rest of the team to make sure we can get through those things. And if you need some extra support, if you've got a relative, if you've got an advocate, if you've got a support person, if you've got a nurse navigator, if there's somebody who's going to come along with you, feel free to bring them along. So because sometimes you don't retain all the information at once, and you might need somebody to explain things or to reflect on things afterwards. So do not feel overwhelmed, but don't abandon the GP who's been looking after you all along.
Great advice. Thanks, Konrad. Yvonne, I might come to you next, and reflecting on some of the statistics that Hayley shared around the impact of heart disease and diabetes. Just wondering if you could share with the group a little bit about your diabetes diagnosis and what you learnt about the link between diabetes and heart disease.
So originally, I was always very thin, size 8 to 10, really healthy, really active. And I started coming down with sore throats, earaches, flus, colds. I just couldn't shake things. I was always exhausted. I'd actually gained 20 kilos within 4 years. And I knew for myself that was not normal, going by how thin I had been previously. And I kept seeing my GP and she said that I was a hypochondriac, basically go away, there was nothing wrong with me. I kept asking for so many blood tests and she kept saying, oh, your sugar's a bit high, but just exercise and it'll go back to normal, which obviously didn't happen. And I did blood tests and she basically said there was nothing wrong with me. She asked me if I was peeing a lot or if I was thirsty, to which I replied no. And then she said, well, then it's not diabetes. So she was testing me for everything under the sun. And obviously all these tests came back negative and I just kept getting sicker and sicker. And one day I just begged for another blood test and then that showed up. My blood glucose was raised a little bit too much and then she said, yes, you've got type 2. So immediately she sent me to the pharmacy to get the blood glucose monitor. She also gave me all the information about diabetes, New South Wales, I think it was at the time, and also the paperwork for NDSS. It was quite a lot to process. So I basically knew nothing about diabetes when I was diagnosed. I didn't know anything about heart disease, and I certainly didn't know the link between the two. But now I'm much more well informed. So now I know all the details. But at the time, I had no idea, and it was a shock. First of all, I was basically angry for a long time because I thought, I came to you for help and you kept brushing me off, and I knew there was something wrong with me. And basically, once I was put on the Diabex extended release, I felt better within 3 days. And then I took up dancing and I lost 20 kilos. And my HbA1c went back to normal. My blood glucose levels were in a normal range. I had to stop dancing though because I've actually got arthritis in both knees. I also developed asthma and I've got glaucoma as well. So I've got a few other things going on which stop me from fully exercising as I would like to, but there are other factors that I can modify to keep myself healthy. And it's been quite a journey.
Yvonne, thanks for sharing that. And I might come back to you, Dr. Konrad, and ask, I think, a pretty big question that might require a slightly longer answer than we've had so far. But why is it important that people do persist and make sure that they're engaging with their GP, to points that both you and Yvonne have raised? And what kind of advice might they expect to receive from their GP about what they can do to lower their risk of heart disease?
Yeah, absolutely, James. Look, diabetes sucks. Diabetes is a rotten condition that you don't know about until it's causing lots of problems. But for most people, sadly not as dramatically as for Yvonne, but for most of us, we don't. There's no real simple thing. There's no wheeze that happens with diabetes. There's no change. There's no rash. There's nothing. This is a silent condition that comes on over a long period of time. And in fact, so is heart disease. Cardiovascular disease is one of those things that you don't know about until actually it's too late and there's dramatic things that are going on. So prevention and being aware of the risk is everything. And as Hayley pointed out already, we know that just by the mere fact of the diagnosis of diabetes, our risk of cardiovascular disease goes up between 2 to 4 times. That's a horrible implication to have on your ongoing health. And that's why as soon as you get the diagnosis of diabetes, it can all of a sudden become this overwhelming where you've got to have this medication, this medication, this medication, you've got to do this, you've got to do this, all for something which you didn't even realize was there. You felt perfectly well for most of the time. It was just a blood test, and now all of a sudden you've got to take all these medications. So we get it. We get it that it sucks. But it's also really, really important to understand why we make these decisions and what those decisions are based upon. So Hayley already mentioned that we know that with diabetes, there are changes that happen in the blood vessels and subsequently in the heart as well. And we talk about those simple concepts like stiffness and stickiness. And it's not all just about glucose. Yes, glucose plays a part, but there's other damage that happens as well. So long before the actual diagnosis of diabetes has come along, the high sugar that Yvonne was describing is already doing some damage to the proteins inside the blood vessels, to the nerves, and to the very tiny vessels. There's already damage that's happening. And it is making the arteries tighter and stiffer and stickier. Now, even a tiny change in the diameter of something like the carotid arteries up in the neck by just 0.1 millimetre, you're almost talking about hair breadth in size, can put your risk of cardiovascular disease up by 40%. So it doesn't take very much damage to do this. Now, why is that important for us when we're talking about diabetes treatment? Is that we actually have got treatments that can make a difference in this area. So you might have normal blood pressure, or normal-ish blood pressure that's never been a problem before the diabetes came along. You might have had cholesterol that was sort of a little bit high, but it wasn't really an issue before diabetes came along. You might have been able to get away with a couple of cigarettes with a beer or a wine on a Friday night before diabetes came along. But then all of a sudden everything changes, that the urgency about doing something about this goes up dramatically, as Hayley said, 2 to 4-fold in time. So even simple interventions that can change and relax the arteries a little bit, and we talk about groups of medications like the angiotensin converting enzyme inhibitors or ACE inhibitors. Ramipril is a simple example of one of those. We had a trial going back, the HOPE trial, which was released back, which was in fact even before 2005, which showed that we could actually reduce the chance of even just a 10 milligram dose of Ramipril once a day. We could bring the likelihood of heart attack down by 19%. And for people who didn't even have diabetes, we brought their risk of diabetes diagnosis down by 34% at that time. With another group of medications we commonly talk about, with the ones that bring down cholesterol, we had this trial called the CARD study, which was once again more than 20 years ago, which showed that even a small dose of atorvastatin, even 10 milligrams, was associated with a 37% reduction in risk for heart disease. So this isn't even talking about glucose. We often think that just managing your diabetes and your heart disease risk is about bringing glucose down, but it's all about protecting those arteries, which is so very important. Now, all of our thinking around cardiovascular protection and diabetes was really turned on its head a couple of decades ago. And many of you will remember the days of pioglitazone and rosiglitazone. And there was this big cardiovascular scandal about, all of a sudden we're having all of these heart failure deaths. Now, what has happened subsequently to that is, number one, we've reversed those study findings because the studies actually weren't all that well constructed. But now you can be ultimately confident that the diabetes drugs themselves are the closest studied of all of the medications on what happens with heart disease. They all have to do what's called cardiovascular outcome trials these days. You don't get that with antibiotics, you don't get that with antidepressants, you don't get that with your arthritis medications, but your diabetes drugs have to do these cardiovascular outcome trials. And we saw that, in fact, when you're looking over generally about a sort of a 5-year time frame, that these medications, these newer ones, the empagliflozin, the saxagliptin, the semaglutide, are associated with a reduction in risk anywhere between 14 and 33% in the heart disease risk compared to usual care. Something which is not like you're not on any drugs, but just on what your usual care is. And we are very, very fortunate in Australia where we don't have to scrimp and save to be able to get these medications. If your GP says, you know what, this is the right medication for you, you're eligible on the PBS to get the subsidy, you could be on 1, 2, 3, or even 4 of these medications, which we know all accumulate in lowering the reduction of your cardiovascular risk. But it's still a big, big step to take, because as we said, you started off not feeling sick at all, and now all of a sudden you're taking 1, 2, 3, maybe 5 or 6 medications every day, and they can all have side effects. And the side effects can sometimes seem overwhelming. What we fortunately know with these medications is that some is much, much better than none. So even if you can't get right up to the whole dose of your cholesterol medication, even if that blood pressure medication is making you feel a little bit dizzy at the start, even if you feel as though your sugars are coming down too fast and you're getting a bit fatigued or a bit woozy on the new tablets that you've been started with, don't stop them altogether. It might be that we just need to back off a little bit on the dosage, because it is a lot for your system to take on all at once. But most often, if you can work together with your GP, your diabetes educator, your pharmacist on, I've got all of these drugs, do I have to take them all together? Are some of them meant to be with food? Are some of them meant to be after food? Can I take half a tablet of this or half a tablet of that? We can usually find out ways to get through starting and remaining on these medications to give you the best effect, because we know as health professionals looking after you that the benefits of being on these last and last and last. And for many of our patients with type 2 diabetes, they actually end up at a far lower risk of heart disease than they were prior to their diagnosis, because we've got all of those risk factors properly modified, and you're eating better, and you're getting the exercise, and doing better overall. So don't get disparaged if it feels as though, well, I've got to go ahead and, you know, all of a sudden do all of this, because the benefits are far, far, far better than sticking our head in the sand and saying, oh, I'll just do better with my diet and I promise I'll exercise more, because we know the evidence is out there.
Thanks, Dr. Konrad. Huge amount of information in that. And again, I'd invite participants in our webinar tonight to, if there are questions that have come out of the information that Dr. Konrad's just shared there, encourage you to enter into the chat and drop a question that we can come back to. We have had some reflections, though, Dr. Konrad, to what you were speaking about around the number of medications that people are on and the mix of medications that they're on to manage both their diabetes and risk of heart disease. Hayley, I might come to you. I think that was a really great explanation of particularly some of the treatments, and Konrad at the end of his answer there spoke a little bit to some of the risk factors and some of the behaviours and activities that people might be considering or might be changing after their diagnosis of diabetes, or where they see that there's some risk of heart disease. What are some of the important practical things people can do to reduce their risk of heart disease?
Yeah, I guess the good news is there's lots of things that people can do. The first thing that Konrad has already mentioned is physical activity. I think if that's the only thing you change, and that's just becoming more physically active, that has a huge impact on preventing diabetes, but also managing diabetes. So the physical activity guidelines for all Australians at the moment recommends that we do about 30 minutes a day. Now, that might be a little intimidating for some people, and you might think, well, I can't actually do that in one go. But the research is actually showing us that you can actually break it up into little chunks and get the same benefit. So it could be 15 minutes in the morning, 15 minutes in the evening. So I'd challenge you now, thinking about your own exercise patterns. If you're currently sedentary, pick one day next week where you just choose to be a little bit more active and start from scratch, and then just build up to that 30 minutes a day as you can. That's the first thing. The second thing would be eating a healthy, balanced diet. And we do recommend the Australian Healthy Guide to Eating, which again is for all Australians. But the one thing that I would mention for people living with diabetes is it all comes down to those carbohydrates that we eat as well. So it could simply be swapping some things that you currently eat. So for example, if you're eating white bread, swapping that to multigrain bread, if that sits well with you. So anything that's usually a little bit higher in fiber is going to break down a bit slower. So it means that you're kind of avoiding those peaks and troughs across the day. Okay, so that would be another tip. And a dietitian is a really good start for that too. And just remember, you can use the dietitian and the exercise physiologist through your chronic disease care plan through your doctor where you get those 5 sessions per year. The third thing I'd also like to touch on is just getting yourself a really proactive GP who's on top of all of your bloods as well. So as Konrad has mentioned, keeping an eye on blood pressure and also keeping an eye on cholesterol. So hopefully, if that's not already happening, try and request that as part of your health profile as well. And the final thing is just looking at our body weight as well, and not so much our total body weight, but where we actually store weight. So it's more detrimental to us around our midsection, which is where all of our major organs are. So yes, we're trying to reduce our overall weight, but particularly around the midsection, that absolutely reduces our risk of developing diabetes in terms of insulin resistance, but also maintaining healthy body weight as well. Oh, there's one other thing, smoking. Smoking is also a really big risk factor for developing diabetes as well. The analogy I like to use is if you imagine you're hosing your garden, that water that's coming freely out of that hose, that's normal blood. If you now imagine someone who smokes, now imagine tomato sauce coming out of that hose. So it's thicker, it's gluggier, and it's got that opportunity to stick to the sides of the vessels. So if you are a current smoker, there's lots of different ways that you can stop smoking. So have that chat with your GP and see if you can work towards quitting. Thanks, James.
Thanks, Hayley. Again, a fair bit of information there, and encouraging people to enter questions into the Q&A if you want to pick up on any of those, or go into a little bit more detail on any of the points the important points that Hayley just raised. Yvonne, can I ask you, tonight's webinar is part of Diabetes Australia Take Diabetes to Heart campaign, which is about inspiring people with diabetes and the people who love them to take positive steps to better heart health. Why is that so important?
I think knowing the risk and knowing the factors that you can modify, and if you can modify those factors that give you a longer, better life, that means you'll be around for the people that you love and they'll be around for you. So I think it's really important, not only for people that have diabetes, but for everybody to keep their heart healthy.
Thanks, Yvonne. I think that's absolutely right. Can I thank everyone who's starting to throw questions into our chat, and otherwise they're starting to come through, and there's some really interesting questions, so thank you for that. The first one I might direct to you, Hayley. This question has come in. Someone's asking, sometimes my blood glucose level is 7 before I go to bed, then I wake up and it's 8, but I haven't had any food and I've just been laying and sleeping. Can you explain why it changes in that way?
Yeah, this is actually a really common question that we get, James. So as you say, someone may have already had their dinner, they've checked their glucose 2 hours, they're about to go to bed and it's 7, for example. They haven't had any food, and then they wake up and it's a whole point higher, which can be quite frustrating, and people are wondering why that's happening. We do have what we call the dawn phenomenon. So, and it happens for people without diabetes as well. When we rise in the morning, we get a bit of a surge of cortisol, which is a little bit of a hormone that helps us get ready for whatever we're about to do that day. So that's one reason why our levels can be a little bit elevated. It's not necessarily a reflection on the food that you ate the night before, because much of that has already been digested. So that's one of the reasons. It could be also depending on timing of medications as well, and Konrad might be able to elaborate on that a little bit as well. And that's probably the main reason. And it's also sort of a reflection on how well the liver is working overnight. So the liver is a bit of a storage unit for any excess glucose. We use that glucose during the night because that's the only time we don't eat food. So to help us breathe, to beat our heart, to restore our muscles, much of that glucose will come from the liver. So there's a couple of little things going on there. But again, have a chat to your doctor or your diabetes educator, and they might be able to help you tweak a few things to, help reduce that morning number as well.
Konrad, I think there was an opportunity there for you to add anything to that answer.
I mean, look, I think that it's not all about the glucose. Is certainly my message, and that 7, 8. We don't get terribly petrified about the subtle differences in those numbers. Absolutely, Hayley is correct that if all of your medications are being taken in the morning, they do wear off over 24 hours. And so it's quite likely that overnight your medication, the effect of your medications has worn off. You're back to where you started, and then you take your medications again the first thing the next morning, and down comes your sugar again during the night. But also the other important thing that we have to remember is that one of the big cardiovascular risks that we often overlook with diabetes is sleep apnea. And for anybody who's actually got sleep apnea, which is particularly if it's being not treated properly, that increases your risk as well. Your heart is having to work harder overnight. All of that activity is going on. As Hayley mentioned, your cortisol levels go up, and that can drive up your sugars as well. So if you're really stumped thinking, what on else is going on? And you don't have a partner who's saying, oh, by the way, you actually, snore all through the night and I have to jab you in the ribs to make sure that you wake up, it might be worth seeing about getting a sleep study done if you can't work out why your early morning sugars are so high.
Thank you. We've got a really, I think, sophisticated audience with us tonight, and they've got some relatively, I think, sophisticated questions that I might start going through. Konrad, I might direct this one to you, and I'm not sure that I'm going to give the question justice because I think it's come through fairly briefly. People are getting tested, getting cholesterol tests and other tests fairly regularly. And the question that's come through here is around the importance or otherwise of the LDL and the HDL ratio rather than separate levels. I wonder if you can, A, explain that for our lay audience, and B, talk about what the importance is of understanding the ratios and the levels and some of those numbers that people see.
Absolutely, more than happy to tackle that, James. And look, I'm not a cardiologist, and the cardiologists would love to be able to answer that question. But I'll give a really simple summary of what happens. So basically, when we eat food, when we eat fats, it's absorbed. We chew it up, we swallow it, goes down into the stomach, hits the stomach acid, all gets dissolved up, goes across into the first section of the small intestine called the duodenum, and that's where it starts to cross into the bloodstream. So our saturated fats are fats, they're fatty acids, and they cross over into the bloodstream as triglycerides. They're pretty much untouched. They haven't really had much done with them. So elevated triglycerides is a bit of a marker of what is happening with the dietary fat intake or the saturated fat intake into the diet. If you go and have a sausage roll or a slice of pizza before you have your blood tests, half an hour before your blood tests, we can guarantee your triglycerides are going to be through the roof. And that's why we ask people to have their lipids done as a fasting blood test. So it takes that immediate dietary part out of it. Now, once the food has crossed into the duodenum, the blood flow from there takes it into the liver, and it's in the liver that those lipids, the fatty acids, then get bound to proteins. The way that our body uses fat is as cholesterol, so it's called a lipoprotein. Lipid being the fatty acid, and the protein that transports it. Now, in the first stage, that is a loose globby structure. That's called low density lipoprotein, or LDL, or even very low density lipoprotein. And it's big and it's globby, and it's got a bit of a positive charge on it. So when you've already got damaged blood vessels that are stiffer and stickier than they should be, that LDL, or that low density lipoprotein, is the stuff that sticks to the sides of the arteries and will actually clog it up over time. Now, if you've actually got the fat going around in the bloodstream and you are doing prolonged exercise, as Hayley mentioned, that sort of 15 to 30 minutes of exercise, you over a period of time you'll start to use up all of the glucose that's available there in the bloodstream, and your body needs to look for other energy sources, and it starts to then want to use that fatty acid, that lipoprotein. But it can't drag that lipoprotein into the muscles to use it properly in that loose globby form. So it has to become denser, and it becomes becomes this high density lipoprotein. So that high density, or the HDL, is the stuff that we can actually store. And we know that by dragging the fatty acids out of the circulation and into storage as LDL, that actually is cardioprotective. So, but it really takes that prolonged activity to be able to do that. We can't drive that just with medication alone. So we look at it as an overall equation. High triglycerides means you're having too much saturated fat in the diet. High HDL means that you're getting lots of exercise and you're converting it. And the LDL sits in the middle of those two parameters. Now, the LDL is the stuff that our medication works on, because as I said at the start, that fatty acid that gets converted across from the duodenum into the liver, there's enzymes in the liver which are doing that binding. And if we've got that enzyme blocked by these medications, the statin group of medications, what happens? Your liver just shunts that stuff straight back out again. That fatty acid goes back out through the bile duct, into the small intestine, and out through the large intestine, and you poop it out. And that's why so often when people start off a cholesterol-lowering medication, especially if it's been started at a high dose, like the cardiologist will put you onto after a heart attack, all of a sudden you've got all of the nausea and the flatulence and the loose bowels, because your bowel is now having to transport all of this fat that for years and years and years you've been actually trapping into your bloodstream. So that's a very, very rough analogy of what's happening, but basically that's why we talk about triglycerides bad, low density bad, HDL good.
Konrad, I might stay with you. There's a bit of chat or a few comments being made in the chat space around HbA1c levels, which obviously as people living with diabetes can be a bit of a focus for us on getting our HbA1c levels right. I wonder if you can just speak to HbA1c numbers and targets and what we should be thinking about as it might be contributing to our heart health and cardiovascular risk management.
Yeah, absolutely. And once again, we'd say that it's not all about numbers. And in fact, your HbA1c doesn't actively correlate with the cardiovascular outcomes. You can have an awesome HbA1c, but if your blood pressure is up, if you're still smoking, if you've got poor cholesterol, you're still going to be at elevated risk of heart attack. You could be having a stubbornly high HbA1c that we just can't get down, but if you've got your blood pressure under control, the cholesterol is down, you're taking a bit of aspirin, you've knocked off the cigarettes, you're going to reduce your cardiovascular risk overall. So it's not just about HbA1c. Now, I often think about the red blood cell like an apple, you know, that we know apples are healthy, but as soon as you go along to the show and you go alongside Show Alley, you've got the toffee apples, that's bad. So our red blood cells, once they're actually coated with glucose or glycosylated, we know that they become deformed. They become more brittle. The surface of the red blood cell becomes almost like crystallized and will break off, and those red blood cells deteriorate much faster. Now, glycosylation, that what we talk about with HbA1c, happens everywhere. Glycosylation happens wherever you've got proteins, to the nerves, to the insides of the vessels in your kidneys or in your eyes, and to the insides of the vessels. So HbA1c is telling us about glucose everywhere, not just on the red blood cells. Red blood cells just happen to be the things that we can easily measure by taking a blood test. Now, we don't set one simple target anymore. For years and years, we talked about a HbA1c of 7% or 53 millimole per mole per litre as the target. And that's still a pretty simple default, but we know that that's different for different people. If you're young, if you might be planning a pregnancy, if you know that you're going to be doing a lot of activity, we might want to get that HbA1c down much lower, maybe 6.5 or even 6%, and we'll push harder with the medications. If you're older, if pushing your HbA1c down low is going to start increasing your risk of hypoglycemia and falls, we might actually say, you know what, an 8% is actually fine with you. So it's important to negotiate your targets with your GP, with your CDE, with your care team, to know what actually are the numbers that I'm looking for. Because yes, of course, we want everybody to do as well as we can, but as GPs, we see that whole picture and we don't just focus on that one number. And if we are going to pursue a low number, we want to make sure that we do that safely and without putting you at risk of further side effects.
Terrific. Thank you. Yvonne, I might come to you next with a couple of questions. One, and I think this is great because this is absolutely a feature of the Take Diabetes to Heart campaign, which talks about having these heart-to-heart conversations with our loved ones as well as our GP. And I wonder if you could reflect on how important it is to have loved ones such as family and friends to support you and conversations about heart health. How important is it to have those conversations and to be supported by your loved ones?
It's so important because diabetes is a difficult thing to deal with on your own, and you need as much support as you can to be able to get through day to day, especially if you're not feeling well with other things that can affect your blood glucose levels. Other medication can affect it. Sometimes you just feel downright miserable because there's nothing you can do. And it's just important to have that shoulder to lean on, someone to talk to, and just, other people then can understand what you're going through. They may not understand the link between diabetes and how you're feeling, or how it could affect your other health, generally, especially if we're talking about heart health. So I think it's really important to have a close group of people around you that can support you, because that makes your journey that much easier, because you're on that journey for life. So the more support you have, the more people around you, the better, and then they can learn from you as well.
Thanks, Yvonne. The next question I might ask you, wearing the hat that you wear as a pretty active health consumer, and then I might pivot to Konrad to build on your answer. But Yvonne, one of the points that's come through from someone is, I live in country WA. There's not much choice of GPs in rural area. Can you provide any thoughts about access to healthcare for people living in remote areas? And Yvonne, I'm directing that to you because this is something that health consumer groups, including some of the groups that you're involved with, talk about all the time, right?
Yes, and I think now able to contact your doctor via Zoom, have a meeting that way. I think that has made things much easier, that you don't have to directly be sitting in the office opposite your GP. You can conduct a consultation over the Zoom, which I think then makes it easy because you don't necessarily have to be in your town or your city or even your state. So I think that makes healthcare a lot more accessible to more people, and that way they can get better treatment. They're not limited in that way.
Thanks, Yvonne. And absolutely, I agree. Access to Telly Health being far more accessible, particularly since COVID, has been a bit of a game changer for people in rural areas accessing their care teams. Konrad, I wonder if you want to add to that, to the concern coming through the chat for those people living in rural areas for whom accessing healthcare is just even more difficult for those of us in the big cities.
Well, I mean, James, this is everything to me. I am a GP in a rural area. I'm in North Queensland, and the entire reason why I became so engaged with diabetes care in the first place is exactly that concern that I'd heard so many times. When I was a junior GP, we didn't have strong diabetes services available. The nearest endocrinologist was more than an hour away, and that's when you could get in to see them. So I made the decision, no, I need to step up in my knowledge and understanding of this condition so I can help the people who are part of my practice. I'm not a diabetes specialist. I'm a GP who does lots and lots of things like all rural GPs do. I just think that diabetes care is really, really important. So every GP will have some skill in this area. But also, if your own GP doesn't have a lot of skills, they'll certainly be able to put you in contact with other services that do. And the most important one there is certainly going to be your diabetes educator. And we are very, very fortunate that so many of our diabetes educators in Australia are now so much more telehealth professions than, in fact, most of my GP colleagues, that we've got CDEs who are giving great online and virtual care and services. And that isn't always about you being able to pay for it either. It might be that actually there's an outreach service that you're able to be put in contact with no matter where you live. We've got those services. Really just comes down, if there's a phone signal, we can get care to you. The other beauty about diabetes is that unlike conditions maybe like asthma or epilepsy, it's not all about you being right there for the examination. A lot of it is actually about, tell me about your numbers, we'll go through your test results, tell me about what your experiences have been. Exactly as Yvonne was just mentioning, that it's not just about you being right there in front of the GP at that time. So it may actually be that your GP for your diabetes care is more remote, but needs to be able to work in conjunction with your usual provider. The other part too is it isn't just about the GP, or in fact even about the diabetes educator. It could also be about your pharmacist. It could also be about the optometrist. It can also be about the podiatrist and the dietitian and all of the other health professionals we've got around you. That whatever your care network looks like, it needs to work for you and be there for you. And wherever you are, we have got excellent services. And now we've even got further enhancement of our care availability in Australia. We've now got these wonderful nurse practitioners and nurse navigators who are also far more proficient and can step up and actually help out with the prescribing, the adjusting your medications, the ordering of your tests, so that even if you can't get to the GP, there might be a advanced care nurse in your area who's able to help you out. So yes, I would love to say that every GP is going to be able to help you out, but sometimes we just have to be a little bit flexible in our thinking about who are the people around me who can help out, and what are the options that I might be able to explore with them.
And Hayley, I might just come to you to build on this one as well, because it is such an important issue for people in rural and remote Australia. As a diabetes educator, are you delivering Telly Health, and what are you seeing from allied health professionals, including CDEs, certified diabetes educators, the way that they're changing to make sure that their services are more accessible to people who might be further away?
Yeah, I think the telehealth model is definitely growing, particularly we've come out of a COVID epidemic where at some point that was the only way patients could see health practitioners. So not only GPs, but most of your allied health professionals are providing telehealth these days as well. And I guess just in addition to what Yvonne and Konrad have mentioned, if people are quite computer savvy, there's actually quite a lot of online resources now too. I mean, we've got things like carbohydrate counting, we've got fact sheets from travel right through to what do I do on a sick day. So there's lots of that. I appreciate that not everyone's going to have access to that, but that's also another service or resource that people could use. So yeah, I think it's growing, and I think it's a great way, particularly even if you're not necessarily remote, but you're injured and you can't get to appointments. It's just another way to connect people as well. And we would prefer that people are reaching out and seeing doctors when they need them, not waiting till things get really bad. So trying to be really preventative and engaged, and use those 5 chronic disease management plans that I mentioned before. It's a really great way to check in with a podiatrist, dietitian, exercise phys, or a diabetes educator.
Terrific. Thanks. And I think that should be the headline for people from this session today. Don't kind of wait until it's too late. Engage with your services, and particularly with your GP early, and particularly in this area of heart health. Hayley, I might stick with you because you raised the option of some of those online resources. You spoke before about kind of swapping out foods for healthier options. What are some of the resources, even apps or websites or those kinds of things, that you might be recommending to people at the moment to assist them to make some of those relatively small but potentially quite impactful changes in their diet?
Yeah, absolutely. So the NDSS, or the National Diabetes Services Scheme, they've actually got a huge amount of resources online, right through from healthy cooking ideas, healthy snacks. We've got one on the glycemic index. We've got a recipe database in Diabetes Australia. There's the carbohydrate counting. If you are registered with NDSS as well, keep in mind that there are all of those free programs that are done throughout each state. So you can always pop onto the NDSS event page. Some of them are also delivered online. I much prefer face-to-face, and a lot of other people do too. So we do offer them in the both formats. So that's another good way to sort of get information without having to necessarily see an individual health professional. We'd always refer you back to your individual team, but for general knowledge, those programs are really good, and some of those online resources as well.
Thanks, Hayley. Konrad, there's a few, I think, as a non-clinician, some particularly medical questions coming through. I might just fire at, given that we're kind of 9 minutes from finish time, I might just fire at them at you fairly quickly, if that's okay. One question that's come through: I'm due to have an angiogram next month and may require a bypass or a stent. Which is better?
It honestly all depends on what the angiogram finds. So they are very, and once again, I'm not a cardiologist. Your cardiology team will absolutely want to take you through this. But if there is one little narrowing in those arteries, which can be opened up, then the cardiologist is absolutely going to want to just do a stent, if that's all that it takes. But if the cardiologist has a look at your arteries and says, you know what, there's narrowing here, there's here, there's here, there's here, there's here, I'm not going to be able to put stents into all of those places. And even if I do, I know that those other little parts in between are going to clog up in the next couple of years anyway. They might prefer to then go to the bypass. So it is very, very different for everybody for a whole lot of areas. And I've got to also reflect that a lot of the information we've been talking about tonight is about primary prevention with heart disease, trying to prevent the onset of heart disease. If you've already got heart disease in place, such as you might need a stent or a bypass, then all of these medications are going to be much higher in dosage, and the targets are going to be much stricter. And we really have to make sure that you're adhering strictly to those ones. So just that little disclaimer, but good luck for the procedure.
Absolutely. Konrad, the next quickfire one. An endocrinologist told our participant that some people with diabetes might not always feel classic symptoms like acute chest pain if they have a heart attack because of nerve damage that might impact important warning signs. She said that was known as a silent heart attack. Apart from chest pain, what are some of the other symptoms or effects that we should keep an eye out for in that space?
That's right. So that type of nerve damage that the endocrinologist is talking about is what we call autonomic nerve supply. Now, your autonomic nerve supply is all the things that just happen in the background without you really concentrating on it. Your heart beats, your diaphragm moves up and down to keep you breathing, your stomach empties, your intestines move, your bladder relaxes, all of those things that just happen. Now, they've all got nerves that control them as well. So as those nerves become affected by diabetes and lose their function, that yes, you may not get the classic pain sensation of angina. Your stomach might empty slower, and so you tend to have a condition called gastroparesis. You might find that you can't empty your bladder properly, and so the incontinence or the constipation, if it's happening in the bowel, can come along there as well. But we still talk about those classic symptoms. If you're getting left-sided chest pain, particularly if it's radiating to the arm or up into the neck, if you're getting clammy, if you're feeling nauseated, having difficulty breathing, 000. Don't just make an appointment to go and see your doctor. If you're getting any of those symptoms, it is a 000 straight away, and it's got to be checked out properly.
Next quickfire one, Konrad. At what BP values, blood pressure values, would an older type 2 diabetic need medication? Is the question that's come through. I suspect the answer again is kind of it depends.
Well, of course, yes, it certainly does. But as we're older, we know that it's harder and harder to get down to targets because that stiffness that we've been talking around becomes more and more established, and it's harder to reverse. And as we get older, we don't want to do things that are going to make you topple over and have a fall and break your hip. So we do become a little bit more lenient as we're going. If you're up into your 80s, we're not going to be aggressively chasing the blood pressure. But if you're in your 60s, which isn't actually old, but maybe to somebody who's in their 30s, they're going to think that that's an old person. We know that it's not. Then we're going to be talking about maybe 130 over 80 as being the area. We don't want to let it consistently get above 140 over 90 because we know how much damage is already happening in the background. But we don't want to drag you back down to 100 over 60 where we know you're going to get lightheaded when you get up in the morning. So 130 on 80 is a rough guide for us to be working towards.
And my final one of these quick fire questions for you, Konrad. I've type 2 diabetes. I've not been referred to an endocrinologist. Should I be seeing one, or is a diabetes educator and GP sufficient?
We've only got about 400 odd endocrinologists in Australia, and they are all massively busy. So we've got all our type 1 patients, well and truly, I'll be the first to acknowledge, should be under the supervision of an endocrinologist. We've got lots of people who have got complicated type 2 diabetes, who might have other things that are making their care more complex, who certainly should be under the care of an endocrinologist. But the endocrinologists themselves, particularly those who work in the public system, will tell you we are busy enough. If you've got a GP who's happy to manage this and is going to look after it, who is familiar with the targets and the treatment options available, they're more than happy for us to be the ones who are looking after it.
Thank you. Hayley, I might come to you. A couple of variations on this question around the type of exercise that people should be engaging with. So you spoke at a fairly high level about the exercise guidelines. Some questions around a mix of cardio versus strength. Maybe you could just provide a little bit more detail on the type of exercise that's good for people with diabetes who might be at risk of heart disease.
Yeah, absolutely. So aiming for 30 minutes a day, most days of the week, is what we want to target. So that could be things like walking, swimming, bike riding, dancing, aqua aerobics, whatever floats your boat, really. Anything where you're moving all of your major muscle groups, they're the ones that generate a lot of energy and get your heart rate up. And I've just said in a response before, you're sort of wanting to aim for what we call a moderate intensity. So I like to describe that as lightly puffing or able to walk and talk. So as soon as you can't carry out a conversation, that's where we would consider it more vigorous, and you're probably less likely to be able to maintain that for that 30-minute duration as we were talking about before. One thing just to keep in mind, we do recommend 2 strength sessions each week. We do know that with strength training or any vigorous activity like running, potentially jogging, your blood glucose levels can go up temporarily. So do not be alarmed if that happens. They should come down in the hours after, but typically it's another one of those stress responses. If you're asking a lot of your body, it's a bit of a stress response, and there's glucose that's released, and hence the levels go up, but that should come down. But most of the exercise that most people are involved in, like those walking, bike riding, swimming, you'll typically see a decrease in your blood glucose levels. So that would probably be your first port of call.
Thanks, Hayley. We're getting very close to the end of our session tonight. Yvonne, can I maybe come to you with my final question? And reflecting on what's been said tonight and your own experience, and as someone who's really aware of the importance of taking diabetes to heart and of managing risk of heart disease with your diabetes, can I ask what you're most grateful for or most proud of in what you're able to do to manage your own diabetes and manage your own risk of heart health?
I think the main thing is that I took it very seriously when I was diagnosed. I read all the literature I could get my hands on. I'm still using the fact sheets from Diabetes New South Wales that I printed off in February 2011. So I'm glad that I'm able to take that advice, to run with it, to modify my risk. I know I can't do anything about my age or ethnicity, or certain things you can't modify, but the things I can modify, I'm trying my best to eat better, move more, lower my stress levels, and try not to have asthma attacks because that really puts my glucose through the roof. So I think the thing is just living a healthier lifestyle overall is going to help me not just with my diabetes and other things I have, but just generally my whole being.
Terrific. Thanks, Yvonne. Thank you, Dr. Konrad. Thank you, Hayley, for being part of our panel tonight. We have come to the end of our time, so I'm sure there are people clapping in front of their iPads and computers in kitchen tables and lounge rooms across the country. So on behalf of, and some of those messages are coming through the chat now, thanking you for the excellent information, the excellent and accessible information that you've provided tonight as part of this webinar on Take Diabetes to Heart. Can I also thank the Diabetes Australia team that's pulled tonight's session together, and I particularly want to acknowledge Bridget for all of the work that she's put in wrangling us to put this on. For more information about diabetes and heart health, I'd absolutely encourage people to visit the website www.takediabetes2heart.com.au. That's takediabetes2heart.com.au, which includes fact sheets and other resources that cover a lot of the issues that we've spoken about tonight. We'll post a recording of the session on Facebook in the next day or two. We'd like to thank everyone who's joined us tonight for this important discussion on the need to take diabetes to heart. Thanks everybody for joining us. Have a great night, and we look forward to catching up with you again soon. Good night.